Welcome to the Explainer. So today we're doing something a little bit different. We're going to drop you right into the middle of one of the most high-stakes situations in a surgeon's entire career, the consultant viva. It's an intense oral exam. You're about to hear from both the examiner and the candidate as they break down a classic colorectal cancer case. The exam is starting. Let's listen in.
Good morning. Please have a seat. We'll now proceed to your final long case discussion. Are you ready?
Very well. Your final case begins now. I want you to listen carefully to the clinical scenario I'm about to give you.
Thank you. Okay, my approach would be, well, really systematic. The first thing I need to do is get the full picture of this patient's health through a really thorough workup. Only after that can I start thinking about confirming the diagnosis, figuring out the cancer stage, and then, finally, creating a management plan. The immediate priority is just gathering all that critical information.
So the clinical workup really starts with the fundamentals, a detailed history, and a complete physical exam. I'd start by taking a detailed history, and I'd be focusing on symptoms, things like changes in bowel habits or any rectal bleeding. I'd also have to ask about family history of colorectal cancer, especially those hereditary conditions like Lynch syndrome, because that can significantly bump up the cancer risk. After that comes the physical exam, which would include an abdominal exam to feel for any masses or enlarged organs, and of course, a digital rectal exam. At the same time, I'd get a panel of baseline blood tests and imaging to get a sense of the patient's fitness for a potential surgery. So that means a full blood count to check for anemia, kidney function tests, and a coagulation profile. And look, given that a major operation could be on the table, a blood group and cross-match is absolutely vital. A chest X-ray and an ECG will also help us assess their heart and lung function.
Good. You have the colonoscopy report in front of you. What specific details are you looking for?
Right, that report is crucial. First, I need to know for sure that the scope reached the cecum, the very start of the colon, because a certain number of patients can actually have a second synchronous cancer somewhere else. Second, the exact location of the polyp is vital for planning surgery. Hopefully the endoscopist tattooed it with ink so it's easy to find. Third, did they find any other lesions? And finally, of course, I have to review the biopsy result myself to confirm that it's an adenocarcinoma, the most common type of colon cancer that starts in the glandular tissue.
The report confirms a complete colonoscopy and no other lesions were found. The biopsy shows adenocarcinoma. The term they've used is malignant polyp. Define that for me.
Okay, so a malignant polyp is a cancer that has broken through the inner lining of the colon, the mucosa, and has invaded the next layer down, which is called the submucosa. This officially classifies it as a T1 invasive cancer. And it's really crucial to separate this from precancerous conditions, things like carcinoma in situ, where the abnormal cells have not yet broken through that initial lining.
Precisely. And that distinction is the whole crux of the issue, isn't it? The polyp was completely removed during the colonoscopy. How do you decide if that's sufficient treatment or if this patient needs a formal operation to remove a whole section of their colon? What guides that decision?
That decision really hinges on one thing: assessing the risk that cancer cells have already spread to the nearby lymph nodes. To do that, we use specific classification systems to measure how deeply the cancer has invaded. For polyps that are on a stalk, we call those pedunculated, we use the Haggett classification. And for flat polyps or sessile ones, we use the Small classification, which measures the depth of invasion right into that submucosal wall.
I would be analyzing that pathology report for a very specific set of features. Things we consider favorable that suggest just removing the polyp is enough include a well-differentiated tumor, which means the cancer cells still look a lot like normal colon cells. But there are some major red flags that point toward needing a big operation. These include things like lymphovascular invasion, where cancer cells are actually seen inside small blood or lymph vessels, or a poorly differentiated tumor, where the cells just look very abnormal. These signs all suggest a much higher risk of spread.
And what's really striking is just how quickly that risk escalates. If you have no high-risk features, the chance of lymph node spread is less than 1%. But with just a single one of those red flags, the risk jumps to around 20%. If you have two or more, it can be as high as 36%. This data is what really drives the decision to be more aggressive. Correct. So let's assume this patient's polyp does have high-risk features. You've made the decision that they need a formal resection. What is the absolute next step before you even think about booking an operating room? Before any surgery, a full staging workup is mandatory. We have to see if the cancer has already spread. This means getting a contrast-enhanced CT of the chest, abdomen, and pelvis. I'd also check a baseline CEA tumor marker.
Now, if the polyp were in the rectum, local staging with a high-resolution pelvic MRI would be absolutely essential to see its relationship to the mesorectal fascia, that critical fibrous envelope around the rectum.
Excellent. Staging is clear, no distant metastases. Let's move on to your definitive surgical plan.
All right, let's refine the scenario a bit. Let's say the high-risk T1 cancer was in the rectum, 6 centimeters from the anal verge. What are your definitive surgical options, and what are the key principles of the operation?
Okay, for a tumor at 6 centimeters, the choice is basically between a sphincter-sparing low anterior resection, or an LAR, and an abdominal perineal resection, an APR. The LAR is generally what we'd prefer because it preserves the anal sphincter and lets us restore bowel continuity. An APR, on the other hand, involves removing the sphincter completely and results in a permanent colostomy. That's usually reserved for very low tumors that are actually invading the sphincter, or if we just can't get a safe, cancer-free margin any other way. But regardless of which approach we take, the absolute cornerstone of the operation is the total mesorectal excision, or TME. This is an anatomical dissection where we remove the entire fatty envelope containing all the lymph nodes, the mesorectum, as one complete package, with its thin protective wrapping, the fascia, totally intact. This is the technique that has just dramatically reduced local recurrence rates.
How many lymph nodes do you need in that specimen for accurate staging? A minimum of 12.
And your goal for the distal margin? 2 centimeters of healthy tissue beyond the tumor. And a critical part of the TME dissection, beyond just getting the cancer out, is the meticulous preservation of the autonomic nerves. These nerves control bladder and sexual function. An injury here can lead to just devastating long-term consequences for the patient, so they absolutely must be identified and protected.
Good. You've completed the resection. Let's talk about the immediate post-operative period and then the long-term care.
Right. So a low rectal joint, it carries a pretty significant risk of a leak where we connected the two ends of the bowel, what we call an anastomotic leak. To protect this new connection, I would strongly consider creating a temporary diverting stoma, an ileostomy. This is typically reversed about 3 months later, but only after we've confirmed the joint has fully healed with a contrast eddy.
After surgery, the patient would enter a cancer surveillance program. But it's also worth noting that if the polyp hadn't needed surgery, let's say it was a high-risk but non-invasive adenoma, the follow-up would be different. In that kind of case, we'd follow specific post-polypectomy guidelines, like bringing them back for a repeat colonoscopy in 3 years.
All right, candidate, thank you. Let's summarize the crucial learning points from this case.
First, a malignant polyp is not just a bad polyp. It is a T1 invasive cancer. Your entire management pathway is dictated by meticulous risk stratification based on those pathological features. This is the first and most important decision gate, and you have to get it right.
Second, never ever take a patient for a major cancer operation without complete staging. For colon cancer, that means a CT of the chest, abdomen, and pelvis. For rectal cancer, it means a high-quality pelvic MRI. Operating without this information is simply unacceptable. And third, for rectal cancer, total mesorectal excision is the standard of care. It's a procedure that is defined by anatomical precision. You must know the surgical planes, you must stay within them, and you must have a deep respect for the autonomic nerves that govern a patient's quality of life. You've navigated this case very well, demonstrating a safe, logical, and structured approach. You highlighted the critical decision points and the evidence behind them. Well done. You pass. And there you have it. Passing the exam is one thing, but the real challenge is taking these clear-cut principles and translating them to the complexities of a real person, weighing the oncologic rules against a patient's own wishes, their other health problems, and the input from an entire team of specialists. That, right there, is where the art of medicine truly begins. Thanks for joining us on The Explainer.